Thank you, IMA Tambaram, for giving me this chance to present a topic on management of diabetes in pregnancy. So, why pregnancy? Why diabetes? The prevalence of diabetes is increasing in worldwide. The impact of diabetes in pregnancy ranges from unexplained fetal loss, congenital anomalies, macrosomia, respiratory distress syndrome, and intrauterine death. The main goal of treatment of diabetes in pregnancy is to reduce the risk of complications and minimize the maternal and neonatal morbidity. To minimize the occurrence of complications, beginning at the onset of puberty or a diagnosis, all adults and adolescents with diabetes of childbearing potential should receive education on achieving glycemic goal prior to conception. The therapy of diabetes in pregnancy in pregedium, that is type 1 and type 2, and gestational diabetes requires a coordinated approach. Since the patient compliance and appropriate educational interventions improve the success of pregnancies. Since the women with GDM have higher risk of acquiring diabetes mellitus 5 to 10 years after giving birth, so managing gestational diabetes is crucial. Furthermore, children born during GDM pregnancies have higher chance of developing type 2 DM and obesity due to adverse intrauterine programming. So the glycemic control and a healthy diet are the cornerstone of diabetes in pregnancy treatment. Diabetes in pregnancy can harm the unborn child even if it is manageable. So the key is to act quickly. The treatment aim is to keep the blood sugar levels normal. The recommendations for treating diabetes in pregnancy is approached by two ways. One is non-pharmacological approach, the other one is pharmacological approach. In non-pharmacological approach, since the diabetes is a lifestyle disease, lifestyle and behavioral change is an essential component in the management of diabetes in pregnancy. All national and international guidelines suggest MNT, that is medical nutrition therapy, together with management and physical activity as an initial mainstay for the management of hyperglycemia in pregnancy. The food plan should provide adequate calorie and intake to promote fetal, neonatal, and maternal health and achieve glycemic goal and to promote appropriate glycemic goal. The food plan should be based on a nutrition assessment with guidance from the dietary reference intakes, that is DRI. The DRI for all pregnant women recommends a minimum of 175 gram of carbohydrates, a minimum of 71 gram of protein, and 28 gram of fiber. The diet should emphasize monosaturated and polyunsaturated fats while limiting saturated fats and avoiding trans fats. As it is true for all nutrition therapy in patients with diabetes, the amount and the type of carbohydrates will impact glucose levels. Liberalizing higher quality nutrient-dense carbohydrates results in controlled fasting and postprandial glucose, lowers free fatty acids, improves insulin action and vascular benefits, and may reduce excess infant adiposity. Mothers who substitute fat for carbohydrate may unintentionally enhance lipolysis, promote elevated free fatty acids, and worsen maternal insulin resistance, as it very much happens in keto diet. Fasting urine ketone testing may be useful to identify women who are severely restricting carbohydrates to control blood glucose. Simple carbohydrates will result in higher post-meal excursion, especially they are taking a ready-made fruit juices and canned food. It will raise the carbohydrate content. Meal plan for each day should contain carbohydrates, proteins, and fats in equal proportion. The breakfast and lunch and dinner should contain carbohydrate in all the 3 servings. Each should contain 45 grams and 2 snacks of 30 grams. The proteins you should advise to take 2 to 3 cups of thick dal or whole pulses per day for vegetarians. For non-vegetarians, 2 eggs per day, preferably the white egg, or cooked chicken or fish 1 cup per day, served with 1 cup of dal. Fats, use 20 ml per day for cooking oil, that is 4 teaspoons. Milk, you have to consume 400 ml of toned milk as a milk or curd. After second trimester, make it to 750 ml per day as milk or curd. Meal plan for a plate of 10 inches radius should contain, half of the plate should contain green leafy vegetables, watery vegetables, and traditional vegetables. The part of the plate should contain proteins, that is dal or whole pulses for vegetarians. For the non-vegetarians, egg or fish or skinless chicken. The part of the plate cereals should contain cereals or whole grains or millets. Curd should be taken around 200 ml for breakfast, lunch, and dinner. Snacks preferably we asked to take roasted or boiled Bengal gram and sprouts or salads. Recommendation for the calorie intake and weight gain during the pregnancy according to the BMI. For the underweight, that is less than 18.5 kg, total weight gain should be minimum of 12.5 kg, maximum of 18 kg, that is 35 to 40 kilocalorie per kilogram per day. For normal body weight, that is 18.5 to 22.9, expected weight gain should be from 11.5 to maximum of 16 kg. An appropriate calorie intake should be 30 kilocalorie per kilogram per day. For overweight, that is 23 to 24.9 kg, total weight gain should be from 7.7 to 11.5, that is 22 to 25 kilocalorie per kilogram per day. For obese patient, the total weight gain should be between 5 to 9. The calorie intake should be 22 to 25 kilocalorie per day. An easy method for dietary guidelines for healthcare providers is given in this table. For the level of the activity and the energy requirement and the total energy requirement. For sedentary worker, the total energy should be, calorie should be consumed should be plus 350. The 350 is for the developing fetus inside the womb, and the total energy should be 2250 kilocalorie per day. For moderate worker, the total energy requirement should be 2580 kilocalorie per day. For heavy workers, the total energy requirement should be 3200 kilocalorie per day. Energy requirements in each trimester should be, in the first trimester 1800 kilocalorie per day, and in second trimester 2200 kilocalorie per day, in the third trimester 2400 kilocalorie per day. Physical activity. Planned physical activity of 20 minutes per day is recommended for all who are capable of participating. Brisk walking or arm exercises while seated in a chair for at least 10 minutes after each meal accomplish this goal. Exercises that use upper body muscles or those exercises which place little mechanical stress on the trunk are preferred, because excessive or aggressive workout will lead to small for gestational babies. Then we are coming to pharmacological therapy. Insulin is preferred medication for treating hyperglycemia in pregnancy, including gestational diabetes mellitus, as it does not cross the placental barrier. Don't assume that insulin is only for the type 1 and type 2 women becoming pregnant and metformin for GDM. Insulin is a preferred medication for treating hyperglycemia in pregnancy, including gestational diabetes. Please take it from me. Insulin remains the gold standard for all women with GDM who fail to achieve target glycemic control with medical nutrition therapy and exercise. There are factors which predict the need for insulin. For example, the higher fasting blood glucose more than 110 milligram and postprandial blood sugar level of more than 140 milligram per deciliter, for that patient we are going to give only insulin. Then early detection of GDM in the first trimester, past history of GDM, older age at diagnosis, higher baseline A1C, elevated BMI, renal or hepatic dysfunction, gastrointestinal intolerance or previous adverse reaction or allergy to metformin, history of major congenital anomaly in the previous pregnancy, hydramnios, macrosomia, maternal and fetal distress, presence of hypertension, preeclampsia, IUGR, and fetal growth restriction. For all this women, we are going to give only insulin without second thought. Then we are coming to the insulin regime type and doses. Insulin regime has to be individualized. So no convincing evidence for the superiority of one insulin regimen over another is documented. In most women with GDM, fasting blood glucose remains normal and they present with postprandial hyperglycemia. Thus, it is preferable to start with prandial insulin, targeting the meal at which postprandial excursion exceeds the target. Starting dose may be 4 units of prandial insulin to be administered subcutaneously, and doses to be titrated based on the self-monitoring blood glucose values till target is achieved. Thus, all the 3 post meals should be monitored and targeted to achieve the glycemic goals. We usually do a 7-point profile or 5-point profile. It is appropriately done for an appropriate patient. If fasting blood glucose is more than 110 milligram per deciliter, Preferable to use basal or intermediate insulin at bedtime. However, in PGDM, basal bolus insulin regimen is preferred. Most insulins are safe during pregnancy, and all conventional insulin, both short-acting as well as intermediate-acting insulin, can be given safely in the pregnancy. Most insulin analogs are safe during pregnancy. This include rapid-acting analogs, including Aspart, Fiasp, Lispro, basal analogs including Detimar and Diglutag. Pre-GDM may require pre-meal regular or rapid-acting insulin and bedtime basal insulin. However, pre-mixed insulin twice a day may be an option in women with pre-existing type 2 DM, where a basal bolus regimen is not possible. Obese patients may require higher insulin dose than non-obese individuals. Insulin pump therapy, that is continuous can be offered for optimal glycemic control in patients who cannot afford it. It can help address daytime or nocturnal hypoglycemia or prominent joint phenomena. Then we are coming to oral hypoglycemic agents. Metformin and glyburide should not be used as a first-line agent, as both cross the placenta to the fetus. Other oral and non-insulin injectable glucose-lowering medications lack long-term safety data and are not recommended. Metformin, when used to treat polycystic ovarian syndrome and induce ovulation, should be discontinued by the end of the first trimester, as studies shows no benefit of continuing metformin in preventing GDM in such cases. Only when insulin is not possible or feasible or acceptable, metformin may be used after 12 weeks of gestation, after discussing the pros and cons of metformin in light of all emerging evidence. However, due to the potential of growth restriction or acidosis in the setting of placental insufficiency, metformin should not be used in women with hypertension, preeclampsia, or at risk of intrauterine growth restriction, where insulin remains a drug of choice. Initial dose of metformin is typically from 500 mg per day for 1 week and followed by twice daily administration thereafter, with a maximum dose of 2500 to 3000 mg. If blood sugar is not controlled with the maximum tolerated dose of metformin and medical nutrition therapy, insulin should be initialized without further delay. Hypoglycemia and weight gain with metformin are less in comparison to insulin. However, the risk of prematurity is slightly increased with metformin. If insulin is required in high doses, metformin may be added to the treatment. The dose of insulin and metformin is titrated as per the blood sugar level and follow-up schedule. Monitoring fasting blood sugar and 2-hour postprandial blood sugar is done every third day or more frequently for insulin, and bi-weekly for metformin dose adjustment to maintain normal blood sugar levels. And lastly, glycemia before conception matters as much as during pregnancy. This is the ADA 2026 guidelines, recent updation in ADA. Thank you for patient listening. Thank you.